All right, welcome back everyone to another virtual shouting session at Hearts for Health today. Hope you were able to join us for our shouting session earlier this week, and we're glad to have Dr. Mitrani here for our session this Thursday. Dr. Mitrani is the Chief Science Officer and co-founder of Organocell Regenerative Medicine. We're going to be hearing a little more about that during our presentation today. We also, for those who are new, a few reminders. We'll have a Q&A at the end of this session and our other sessions. So if you do have any questions, feel free to type them in the chat. The chat should be either to the right side or just below this video here, this live stream. So you can go ahead and type any questions you might have, whether that be around what regenerative medicine is as we go through this presentation, really anything. It doesn't necessarily need to be now, it can definitely just be as we go through. And we will be going through those questions in the order that we receive them, just in fairness of our question submissions. Also, if you want to be in tune with our other shouting sessions, like I said, we did have one earlier this Monday, and we will continue to have one session on Mondays and Thursdays. For the rest of the fall semester, we will have a break between, I'd say, mid-December, I think, and mid-January. We'll give more of the details when that time does come around, but for now, know that we will still continue with shouting sessions next week, Monday and Thursday. We will have a quick break for the winter, and we're going to resume for the spring with more shouting sessions again on that same schedule, Mondays and Thursdays. But you can either follow us on our Instagram page or hop onto our listserv, our email listserv, I should say. That email listserv is just a weekly email we send out. Include shouting sessions, the flyers for these sessions, similar to that you see on our Instagram page. And it will also include opportunities, for example, like our volunteering programs or a mentorship program when they open up. We just recently opened up those programs. We actually have 2 volunteering programs open at the moment, and then our mentorship program also open, which is open to pre-meds, pre-PAs, pre-pharmacy, and pre-dental students. So 4 categories of pre-health students. It's pretty comprehensive. So if you'd like to apply, you can take a look on our Instagram page, and you probably have got it already if you are on our listserv. So those are the 2 ways to go about it. Like I said, you can follow us on Instagram, or if you want to join our listserv, you can either go onto our website. We have a subscription form at any of the pages at the very bottom, or you can just email us at shadowing.h4h@gmail.com. Just include your name and your email, and you'll be good to go. We can manually add you onto the listserv. If you do have any questions, let us know. That was a bit, so definitely feel free to shoot us any questions. But with that said, don't want to take up too much time. Dr. Mitrani, feel free to take it away.
Thank you so much, Michael. And thank you to Hearts for Health for organizing this and inviting me to speak today. Let me share the screen. I'm going to ask the question that we all ask. Can you see my screen?
Yeah, looks great.
Perfect. And thank you, everybody, for joining us today. I'm going to speak a little bit about who I am and what brought me to where I am today. When I decided to go into med school, never in a gazillion years would I think that I would become a physician scientist. And the funny thing is, speaking to a friend the other day, he goes, "Don't all physicians are supposed to be scientists?" And I said, you know what, you're right. Everybody should be doing some kind of research, but that's not the reality. Some fields require more hands-on kind of scenario. And there are physician scientists that practice, and they have their patients, or they are operating and they are practicing research. And in my case, I'm more like a scientist than a physician. I always thought I was going to be in the field of caring patients, and I trained for that. But here I am. Let me get started. So I am from Ecuador, South America. I studied in the Universidad San Francisco de Quito. That's where I got my medical doctor degree. Recently, I just got my plant-based nutrition certification, because if you're not trained in nutrition and you're trying to do preventative medicine, it's almost unachievable. And being plant-based, at least incorporating a lot of plant-based or whole foods into the diet just has shown there's so much science out there that shows how you can prevent and reverse a lot of the degenerative conditions that we face today, especially in the US with the standard American diet. It's so simple to incorporate these things that are so cheap, instead of and replace them from all of the processed foods that we tend to eat. I also have a PhD in neural therapy and a doctor of acupuncture. As I mentioned, I never got to actually practice in the setting of taking care of patients. As soon as an opportunity got presented to us, we really dove into regenerative medicine, specifically stem cells. And today, I would say I am the living proof of, working hard and understanding that if you put all your efforts and you keep following that goal, it takes you somewhere. Going through med school is not easy. But that doesn't mean that it's impossible. It is challenging, and also the reward at the end is incredible, because all you need to see is your patients smiling and getting back to a place where they never thought they will. That fuels everything that you go through. I have a couple of awards. One of the latest one was the top 100 healthcare leaders by IFAH for the job that I've been doing with COVID-19. And certifications, I always, every year, get my certifications updated. Because I'm in the field of human research with investigational new drugs, those are specifically the certifications that I keep. And I had an interview recently in the Campus Rebel magazine. And one of the questions was, if you could go back, would you choose the same profession or specialty? And, I wanted to become an OBGYN for the longest time. I actually set the 7 years through med school. I shadowed an OBGYN and a pediatrician that used to deliver babies in water. And it was more like a more calm setting to deliver babies than the regular, setting that the hospitals have. And I love that. That's what I wanted to do. When internship came around, after 3 months, I said, there is no way I'm doing this for the rest of my life. It was like the hours were really intense. The hospital setting was too much. Nothing that I ever thought I wanted to do for the rest of my life. So at that point, I said, you know what, I'm going to be open to just go ahead with my internship year and just keep rotating through all specialties and see if there's something else that catches my eye. And at the end of that rotation, I had to also prepare my thesis for the end of my MD. And I connected with a neonatologist, and we started working with placentas and with twin placentas. And it was so fantastic because if you've ever seen a placenta, it's like very bloody, and like the structure is pretty, it's not a nice structure to work with. But I had to do this dying situation where we see the irrigation of the placentas, where the arteries and the veins, and I never in my life thought that this would be where I would be working with. 15 years later, we are focused on working with perinatal tissue, the tissue that's between the mom and the baby, placenta being one of them, but the Wharton jelly that's between them. So for me to have the ability to be able to identify, well, where is the amniotic membrane, the chorionic membrane, identify that I can extract the blood from the cord blood, because there's a lot of regenerative cells there. And this has brought us to where we are today after 15 years of hard work. We are a public company, a publicly traded biotech company. We are committed to research, development, and manufacturing of new biologic medicine, and with a very important focus on that, the medicine that can be regenerative, right? Our headquarters, we just moved into NSU, which is Nova University, and this is in Davie in Florida. And where I am right now is our manufacturing facility. We are in Willits in Colorado. We are registered, Organocell is registered with the FDA as a human cell and tissue establishment. So we are, and here's my incredible team. We're from all over the world. And I'm super proud to present the work that we all do. It's not only me, but it is this incredible team that sweats it every day. Amazing scientists, stem cell scientists, and others that are there. So what is regenerative medicine? This is something that nobody taught us when I was in med school. I still don't think that there is a point where they're teaching regenerative medicine through med school, but it is incredible. It's an incredible field because it's the branch of medicine that specializes in replacing, engineering, or regenerating human cells, tissues, and organs. But most importantly is that ability of optimizing the human's body's natural ability to heal itself. So it is not a theory of we can re-heal ourselves. It is the body's innate natural ability that really organs and tissues can be regenerated if you provide those tissues, those cells with a specific message. So throughout all of these years, we've been working with, at the beginning, we started working with autologous stem cells, and we're going to go a little bit about this. So at the beginning of my career in regenerative medicine, we worked with the patient's own stem cells. So you can harvest these stem cells or these regenerative cells from the patient's own body. At the beginning, we worked with the hematopoietic or the blood-derived cells. And further, we work with adipose-derived stem cells as well. To then transition and understanding that we were looking to work with a more consistent, more powerful, more pure source of these cells. So we switched to perinatal derived cells. Perinatal, as I mentioned before, is those cells that come from everything that's between the mom and the baby, while it is only at C-section, only from donations, only from mothers that are healthy. So there's this big dilemma or cloud that surrounds the word when you say stem cell, that people say, oh, it comes from aborted fetuses, or it's illegal, or it's unethical. When as I'm saying, it's more than 15 years that there's scientists and physicians that have been working with stem cells that come from the patient's own body. There's nothing unethical from that. And also from the tissue that comes from the perinatal tissue. So that only gets collected through C-section when the mom is ready to deliver the baby. And if it's not used, it's usually discarded as medical waste. So we have learned the power of the cells from one side being autologous. And those can, as I mentioned, can be from the adipose tissue or the fat tissue. Sorry about that. And also bone marrow or the bone marrow derived cells, the peripheral blood. And most of you that are familiar with pain management, you can recognize the PRP or platelet-rich plasma. Those are growth factors that come from the platelets itself, right? And those are all autologous therapies. But also, as I mentioned, we've switched into the allogeneic, and allogeneic means that comes from one person and gets donated to another person. So those, mostly of those come, or most scientists are working with placental derived or perinatal derived therapies. In our case, we are working specifically with human amniotic fluid. And as I mentioned before, only comes from healthy moms and babies that are scheduled C-section and that they have donated this tissue. So there's no ethical or moral concerns. And most importantly, this kind of tissues, membranes, have been used for over 100 years. So the safety record is there. And we are taking it one step further. As I mentioned, we were working with cells. And through these last 5 years, we have really focused on switching the therapeutic to the nanoparticles, and more specifically, the messengers that come from the stem cells. So no longer do we work with cells, with those stem cells. So our focus has been really to transition from the cells to the secretions or the messengers that are secreted by these regenerative cells, and that are called exosomes, or they're called also extracellular vesicles. So a little bit, I'm gonna walk you a little bit through this new therapeutic that we have created that's going through investigational new applications under FDA. And Sofen is the drug that we are taking through FDA, which, as I mentioned, is acellular. That means that there are no cells, and they're coming from another person or a donor. That's an allograft. And we're really characterizing and learning what this drug can do and will be doing in different conditions. Everything that we manufacture is for clinical use under CGMP, manufacturing conditions under an ISO 7 clean room. So what are the compositions of this? So as I mentioned, it comes from human amniotic fluid. Is the fluid where the baby is sitting for 9 months. And at term, this fluid is loaded with proteins in one side. So proteins, over 300 of those, cytokines, chemokines, growth factors. These are proteins that have specific signaling molecules that act in different tissues or in immune cells and guide them to do a specific thing. What are those things? And most of the most complete here, or most representative, I would say, are pro-angiogenic. Angiogenic means that they can create more vessels. And when you create more vessels, you bring more nutrition and oxygen to the site of injury, or when there's a problem, usually you're missing vessels. So they're pro-angiogenic. Anti-inflammatory. They're also immune modulatory, so they're able to talk to the immune system, tissue repair, and pro-metabolic. So these are all incredible practices that this specific proteins have over tissues. Also, there is the presence of hyaluronic acid. Right now, hyaluronic acid is extremely used in orthopedic conditions. In the knee, for example, their patients receive hyaluronic acid injections so they can increase the lubrication of that knee. And in the new aesthetic procedures, they're adding hyaluronic acid to hydrate the skin. So hyaluronic acid there's this new buzzing word going around specifically for aesthetics, and it is present in our drug as well. And I always call it the star of the show, or what we have really dove into these extracellular vesicles or exosomes. So when I went to med school, and for many, many decades, century, we always thought that these small little bubbles that were coming out of the cell, because we could see in the microscope the cell, and we can see that they are vesicles coming out of the cell. We thought that were vesicles that were carrying garbage, or they were carrying, the things that the cell did not need anymore. Because we were not able, there was no technology that could actually show us what's inside of this extremely little bubbles. So these extracellular vesicles and the smaller ones that are called exosomes come from inside of the cell. They have to be produced or manufactured inside of the endosome. And every single cell creates their own extracellular vesicle. So if they're healthy cells, they will create healthy exosomes. And if they are cancer cells, for example, they will be creating information package with a pathological or an unhealthy message. So therefore, there's two big routes right now that are working with exosomes, either the therapeutic or the diagnostic. And I'm telling you, for the moment that you are going to graduate and go to practice, I'm pretty sure that this kind of technology will be out there of being able to detect cancers from very early on, because if we can decode that message from that specific cancer that's being carried by the exosomes, we might be able to detect those cancers really early on. And on the therapeutic side, this is where my company is working on, and being able to harvest the message from healthy regenerative cells and being able to translate that message into the area of the problem. So as I mentioned, these extracellular vesicles or exosomes are very, very small. We're talking about between 40 to 200 nanometers. So they're very, very tiny. And this is a little representation of how they're made. As I mentioned, they have to be created inside of the cell, so in the endosome, and they're going to be packing proteins, messenger RNA, microRNA, and other enzymes that get packed into this small bilipid layer bubbles, right? To then being brought outside of the cell, secreted. And at the beginning, we thought that it was only communication between closed cells. Now we have the ability to actually not only see what's inside of these extracellular vesicles or exosomes, but we can target them with specific dyeing and then see how they go everywhere. They actually cross the blood-brain barrier and they can be found everywhere in the system. So this small packet of exosomes are thought to be the future of the best drug delivery. And I think the future of therapeutic and diagnostic, as I mentioned, is specifically coming from here. So now we have the ability of counting them, which before it did not exist, right? So we know that, this is how we've set up our drug, how would I say, the way that we deliver the drug and the percentage of drug is based on the quantification of these nanoparticles. So we have around 200 to 400 billion exosomes or nanoparticles per ml. And you also, not only that you have to quantify how many, but you got to see the size. What is the size of them? For ours is around 100 nanometers. And this is the nanosite is a device that did not exist before. And I'm going to show you how we quantify these nanoparticles. So making sure that we only run it on the final product, we can see the speck of these particles moving across, and the light transmitting can actually measure them and quantify them. So, moving along, we've been working for many years on our preclinical data, the research and discovery of this specific drug. And we were working for two specific conditions, COPD and knee osteoarthritis. Those were the two conditions that we were working our preclinical data. And when COVID happened, we were able to transition all of the information we had for a lung injury model for COPD. We were able to transition it into the acute respiratory distress syndrome that happens with COVID-19, and presented the IND to FDA. IND means investigational new drug application. And after 30 days, we were one of the first companies, if not the first company, that got the approval to use this type of therapeutic to treat COVID-19. And it was incredible from like the team that we had at the time, which was a small team, to take a risk this big and to take a leap this huge. But even though that's where we wanted to go, being able to go through a drug approval for our drug. So it just got expedited thanks to COVID. And we were able to not only get an approval for COVID, but throughout the first year, we got 18 emergency compassionate INDs, which are trials that are a single patient trial. And these trials here are for 30 patients, and they're bigger trials. So after we got the approval of the first trial, we also got approval of single patient trials, and we were able to understand how our drug actually can modify the setting of the illness, right? So we got to learn a lot about it, so much so that we understood and we treated 4 COVID long haulers, which are the patients that have already passed the infection, the acute infection of COVID, but still remain with symptoms. And currently there is no therapeutic. Currently there is no way to diagnose them. And currently there are percentages of that mention 40% of the population that got infected with COVID-19 might have developed COVID long haulers, which is a large amount of population around the world, in the US also. So it is something that we're moving forward with this trial, not only the COVID-19, but COVID long haulers that will be carried to the future if COVID starts dying down, that we're seeing that. We also did an expanded access for a specific group, which is mild to moderate, the ones that just recently got infected. And finally, on the second year of COVID, we were able to finally present our COPD trial, got approval, and our knee osteoarthritis trial that got approved as well. So you can imagine our hands are completely full with these projects. These projects are not simple to execute, because you have to have an army of experts that have to control every single thing, from where you're treating the patients and how you're monitoring the patients, and every time that the patient gets treated or has to come back to the therapeutic or for analysis. There's so many things that you have to go through. So I am going to present today one of the case studies that we were able to publish too. One of these cases that we treated on the very beginning of the pandemic. This was a physician, a surgeon, that he was 55 years old and weighed 79.5. He was hospitalized for 7 weeks due to mild to moderate acute respiratory distress syndrome due to COVID. So is a patient that during the hospitalization was admitted twice at the ICU, but never got intubated. At the time of him being discharged from the hospital, the patient was physically limited due to the severe deconditioning and having shortness of breath while performing limited activities in the daily living. So this means eating meals, showering, and even walking from his bed to the bathroom was really exhausting. So he was extreme fatigue and no will to do absolutely anything because he couldn't even breathe. As I mentioned, this was a surgeon that was operating on the daily basis, but due to COVID, was left with this sequelae or long hauler Also, chest x-rays were taken, and both lungs have had pneumonia when we started the treatment. So we call the beginning of our treatment is called baseline. So what do we look for in the patients? And when you establish the protocol of a research trial, you have to have many things in order, right? But most specifically, what are you going to do throughout the study, and what are the time points and things that you're going to collect to see how they change, right? So they had to have a positive test of COVID-19 so we can really have a positive diagnosis of COVID-19. Patients have to sign an informed consent. We collected demographics, medical history, did a physical exam, and did a chest x-ray. And because we're looking for our drug to understand our drug, how does the drug impact different kinds of population, we're really looking for these inflammatory biomarkers or biomarkers. These are IL-6, TNF-alpha, D-dimer, CRP. We also collected blood to see how everything else on the patient that run a CBC, a complete metabolic panel. And this we did at different dates. So day 0, 4, 8, 12, 21, 28. And patient for this trial was only followed for those 31st days, so a month. Our drug, Sofin, was administered 3 times during that period, day 0, 4, and 8. And everything that we're doing is just to assess if the drug is safe, right? So safety is the first thing when you're doing this type of INDs. When it's a new drug, you have to assess only side effects and adverse events. And then you start evaluating if there is actual efficacy. And you move through the trials from phase 1 to phase 2A, B, to 3, 2, 4, and finally, hopefully, a BLA license. That's where we're going to. So the patient report on the first day of treatment, this patient's the O2 saturation was at 96%. And by day 8, before he even received the 3rd dose, the patient reported no signs of fatigue and shortness of breath. And O2 improved to 97 to 98 after that first dose. And then we also evaluated the chest x-rays. Day 28, there were no more the bilateral pneumonia that he had. Now those lungs were clear and clean. And most importantly, the patient was able to return back to the OR, and he was able to do his surgeries again after a month. So this is, as I mentioned, this is our publication, and I think I had it after this. Yeah. So this was the publication of this specific case report. I just made a small summary, so you get just an extract of what we did and how we follow up this patient. So for us also incredible to be able to publish with my entire team. That was the beginning of all our publications. More publications have come throughout the years after that, and today we just got news that our last publication was accepted. So soon we're going to be able to send that or share that with you. And I always end up my talk saying this because through medicine you're going to face so many medical problems that are not as simple as just for example, I have a cavity or I scratch myself, right? That you can simply help patients. You're gonna face with many patients that their life have been shifted forever because of certain illnesses. And I always find that science and medicine keeps evolving. So this is my little tagline that I came up with. Through through the thickest of COVID, to never give up, because science will show up. And we've seen it through the pandemic, how the entire world came together to formulate a preventative vaccine that was rolled out, and eventually that viral load coming down and shifting. So that is my my little tagline. And here are some. First, thank you for the opportunity of presenting my journey. And I'm active on Instagram and LinkedIn, so please follow me. I'm in Mari Mitrani. My company is Organocell, so if any information you liked from what I have shared with you, keep coming back to organocell.com, so you can see how we keep evolving. As I mentioned, we are going from a phase 1-2 to hopefully get our BLA license, which is being able to get the drug approved and roll into the entire population. So that is me, and I'm open for questions.
Absolutely. Well, first of all, thank you so much, Dr. Mitrani. It was very interesting to hear about the field, especially like you mentioned, given the recent pandemic. This is pretty applicable to hear right now. And it's not something that we've heard, I think, with other shadowing sessions yet. So it's definitely a new field for those listening in. I wanted to kick off the questions just with starting off about your team. How was the process of gathering a team like this? I mean, you showed us a picture, and there seemed to be quite a few scientists over there, I'm sure many being qualified. What was the process of gathering a team like that? I think that carries over to sometimes when other speakers talked about how I know that recently we had a speaker who helped out, or owned, I should say, a multi-specialty practice. He's a pediatrician. So we've heard a little of that, but this isn't a different side of practice. This is, like you said, being a physician scientist. So in light of that, are there any differences with gathering a team also in that same sense?
Yeah, definitely. I mean, I always say that my strongest asset is having my team, and the team has been chosen not only from their accolades and everything that they've achieved. You know, we have several PhDs. All my senior PhDs are in Florida, running the R&D, because we have to do a lot of research and discovery through what we have. Most of these is new. We are paving the world of regenerative medicine that didn't exist. But I give props to my VP of manufacturing, that he has the ability to actually sit with every single person that we have interview, and for him is more important. And he always says, if I can picture myself sitting next to this person and working all day with this person, then I found a winner, right? And I can say we've hosted an environment that is so pleasant to work with, all of this. And I personally think that making sure that we have a lot of young people, and I love to work with young people, because this is such a new field that really brings the best out of all of us. Of course, I work with a lot of physicians, my medical director, and all of the advisory board members that are physicians that have like a long career, our regulatory team that has been working for several decades with FDA. So we are a perfect balance between a younger crowd with an older crowd. But I think the secret of having a very successful working place is having a team that you can count on, and that can really, I always tell everybody we're in a boat and we're all rowing in one direction, and I get that from my team.
I also wanted to ask about your degrees. So you mentioned you had your MD and then also a PhD. Often what we think of as a physician scientist, there's those MD, PhD programs that advertise themselves as physician scientist training programs. Looking back, would you have preferred to take them in one of those condensed programs with those dual degree programs, I should say, with an MD and a PhD? I'm not sure if you took your MD and then your PhD, right?
Yes,
Okay,
yes.
so it's separate.
Yeah, I don't think, I mean, going through your MD years are extremely intense. I don't think I could have done anything more than that. Me personally, I have a lot of friends that did their MBAs with their MDs on the first year. So it was like easier to condense in the beginning. And yeah, I mean, the field of medicine, the beauty about the field of medicine is that it really doesn't matter what you think you like. At the end of the day, life really shows you so many different ways. And for me, I always thought that I was going to be a clinician, that I was going to have patients and see my patients and treat my patients in a daily basis. And here I am conducting research and seeing patients from another angle, right? Seeing patients where we get to really conduct big trials, like double-blinded, placebo-controlled, randomized trials that can be published and can really impact a bigger size of population of patients, even though I don't see them daily. So even I have so many friends that were thinking of being gastroenterologists, and when match time came, they match in pediatrics or other things that they never ever thought they would be, and they gave it a try and they love what they're doing. So it is, your life will go as completely unplanned. That is one thing for sure.
I'm sure, definitely. Also, another question about the same work that you're doing. So, being in the field that you are, I'm sure that funding is required, things that you wouldn't necessarily see with like direct one-on-one patient interactions when you're on the research side that like you are. So, are you the one that has to kind of go outside of what you would see traditionally with a physician and learn those other sides, or is that dedicated to other people on your team?
So we are a public company, and definitely the team that goes out to investors, because we have to do fundraise, a lot of fundraising that is taken by other team members, the ones that are really focused on the financial side, on the investor side, but you still have to be very knowledgeable of the field, because more me as an officer of the company need to know what is the environment and what we're looking for as a company, right? But if there's one thing that I could advise to every single one of you, is that you really do need to know and understand about business, because once you graduate as a doctor, and most of us end up there, knowing and caring for humans and not knowing how to deal with how to care about our business. And it is the most scariest thing. Everybody says physicians make the worst business people, because we operate from the heart. We just want to heal people, but then we have to survive, and we don't know and never learn how to actually say to the patients, this is the bill and this needs to be paid. And patients usually are big negotiators. So we usually give in, and that as a business, they will never, ever succeed. So yes, your MBAs or your little business on the side, you have to learn before you graduate as a doctor.
We also like to ask a question that really fits in with all of these sessions, and it's really for students who catch an interest from the talk that you've gone through. They might want to gain a bit more exposure outside of this session here. What are ways that they can do that? I know that some programs like these with regenerative medicine, with generally like physician scientists on board within their team, they'll have maybe internship programs that they offer. I'm not sure if that's the case for Organocell, but could you take us through any other opportunities that they might have, or if Organocell does have opportunities like that?
Yeah, Organocell at the time is not we don't have, or we're not offering that kind of program of shadowing, more personal shadowing. But I am always open to guide anybody that's thinking about the field or that needs some more guidance. Like I'm very, very open and very happy to do all of that. So again, I'm more active on either Instagram or LinkedIn. Those are the two places that I can be reached out. And yeah, I mean, I do this because I really think that really soon all of you will be joining forces into the healthcare and in any shape, way, or form, and that we all have to work together. So more than happy to help that way.
I remember you mentioned that you attend medical school in Ecuador. So in that environment, was research, extracurriculars kind of the same admissions process, if you will, applicable there, or was it kind of just based on a test score?
I think it was pretty similar to what we go through here. The same really difficult ways to get in and really difficult ways to go through the program and to keep advancing. And yeah, and research the same. Research is usually not taught too much in med school as nutrition. But yeah, the same old
process. Yeah, so I wanted to follow up with that because a student was asking, what research / extracurriculars did you do before attending medical school?
Before attending medical school. So I come from, my father is a physician and my parents run their day clinic. So I had the opportunity because of them to be involved very early on that setting, on being in the clinic. I didn't do anything like before I went to med school. The other thing in Ecuador, as soon as I graduated from high school, there's no college. So you just straight up go into med school. You do the same 4 years of basic or 3 years of basic science, but more geared into medicine. So I straight up went to medical school. But I started rotating at my parents' clinic a lot. So much so that because it's a third world country, and a lot of, as long as you have knowledge and you develop skills, you can help. You don't need the certification or degrees. I used to do a lot of the IV. My parents do a lot of vitamin IVs. So I canalize veins left to right, which is something that usually MDs don't do. We leave it to our NPs or PAs to do that job here. But it's one of the skills that I learned, and I was exposed to treating patients really, really early on my career because of that.
So regenerative medicine, I'm not sure if this is the case, but it sometimes overlaps with preventative medicine in some respects. I mean, correct me if I'm wrong. We have had one session actually with the deputy of health in the counties, one of the counties in California. She presented over preventative and community health. So along your journey to leading up to where you are right now, did you ever consider going into a community health position? Was that something that aligned enough with your interests to ever be a consideration?
Yeah, I mean, I've been doing, or I was trained thanks to my parents in preventative medicine since the beginning. It is time for our healthcare to focus more in preventative instead of being reactive after illnesses are so chronic and debilitating, because we can act so much faster with preventative medicine. So I've always had that entrance of preventative since the beginning. And one of those reasons why I took my nutrition certification, and many others, like many other things that I've done, is really focus on preventative medicine. And again, I really thought that I was going to be a clinician. I was going to be acting daily with my patients, and that didn't end up going that way. But that doesn't mean that in the field, in the position that I am, I'm not verbal about it. I'm very, very active on that, on understanding that not only nutrition, not only being able to work out, even moving daily can help, but sleep patterns, social environment are very important for all of us as humans. So I love the blue zones. And if you've never heard about the blue zones, read about them to understand how can you get. They analyze the longest living population that are the healthiest. And they have 6 to 8 things that are really common throughout all of these communities throughout the world. It's very, very interesting.
Also, just day to day, does your day look fairly consistent, or is it pretty variable? And if you could provide an example of, let's say, one day, what it looks like to be in your position, that'd be great, just for students to get like a sense of how it is to work as a physician scientist. What would a day look like?
Yeah, so my days are extremely hectic and very different from one to the other. Also, I'm an entrepreneur and I am part of managing this company, right? So it is not only my role as a physician scientist that is inside of the lab, for example. So I not that I am inside of the lab doing all of the testings and running the things or manufacturing, for example, but I oversee all of this. So I'm here. We just opened. We're more than eight months, but we're really certified and running our manufacturing here in Colorado. So I had to be here in Colorado to make sure that the entire team understands and we adapt as a team for manufacturing. So, for example, yesterday I was in helping processing, running through all of the motions from the beginning to the end. But I also have a lot of calls today. We were in a 2-hour call with the CDC and University of Oklahoma because we're collaborating with them with research. And as I mentioned, we have those 5 approved INDs, 3 of those that are very active, and patients that being enrolled. And we have to be on top of, if the patient was enrolled and they had to have, let's just say, chest x-rays and blood had to be drawn, we got to be on top of all of that, right? And another side is that we are actively writing and producing publications. So reviewers get back to you. And the month of October has been extremely crazy because I've had to go to a lot of congresses. So I've been flying out to talk about everything that we do. So it's been flying, and I say as long as I have Wi-Fi and cell service, I can work from wherever. And I'm a little workaholic, so I do work a lot. I carried on from my med school years, that practice of, always being alert, always being ready to work, always being ready to solve problems, right? I think that is what we learned throughout med school, how to solve problems in the best efficient way. So I don't have a regular schedule. I have to, and then we have our laboratory, our R&D laboratory, also manufacturing laboratory in Florida. So I do fly a lot and work with the team there as well. So hectic.
Actually, our next question is as to the comparison between what that work-life balance looks like, what you just mentioned there, and how it would look like if you were in practice. What contrasts would you say are most striking between those 2 practices, those 2 ways of practice?
Yeah, I think when you're in a clinical setting, you have more a defined schedule, right? If you are in your private practice where you can shift your schedule, which is still very hectic because you never know what patients, even though you have patient schedule, usually that doesn't translate to that specific schedule. Different than being in hospital where you also have a schedule, but it's more days that you have to stay longer in the hospital. but you still have a specific schedule, and you know what you're doing and what you're going to be up to, right? With my specialty, I really don't have a structure, a schedule, right? Some weeks I am all day in calls. Some weeks we're process manufacturing. So it's very, very different.
Another student asks, how did you become interested in aging and what opportunities are there in that field?
Oh, yes, anti-aging, I think it's moved to the top priority of every single specialty. I work with our advisory board members. I have OBGYNs, I have urologists that you would not think that they are interested on aging, but their patients are. And the patients and the population is getting healthier and older. And when they achieve, they're retired, and they have money, and they are not functioning as they want to, they are seeking for anti-aging hacks, let's call them, right? And I think we are the ones that have to be on top of the game to make sure that we separate the quacks and the misinformation that's out there to the things that actually can be done to improve the quality of life of our patients that are older. And there's so many companies that are really wanting to go for frailty and anti-aging, and there's a lot of money being thrown there on anti-aging specifically. So the opportunities, I think they will only keep growing because the shift is in that direction.
Another great question, because we do have some pre-PA students outside of just our pre-med population join in on these sessions. So are there opportunities for mid-level providers like PAs or nurse practitioners to involve themselves in regenerative medicine and the type of work that you're doing?
Oh, absolutely. I would say, even though the protocols are handed to MDs, most of PAs and NPs are the ones that are doing the work, specifically for the aesthetic side, for example. They're the ones that are providing the work. Even on all of these trials that we have with FDA, they're IV infusions. So PAs and NPs are the ones that are doing it. And it is growing the field of NPs and PAs that are getting more interested in regenerative medicine and there's a lot of associations like the A4M, which is the American Association of Anti-Aging, for example. Just to give you one example, very popular, where you can get certifications through them. In any healthcare provider that is in that field can get different levels of certifications through them. So there's a lot of associations that do provide certifications besides the university and the master degrees that you can actually find in your specific field. But definitely the field is growing. So
Sure. One more question just to wrap up the hour. I'm not sure if this is the same thing or if this does have a difference, but I thought to ask, I thought it'd be interesting. You mentioned earlier that there are therapies that you develop within Organocell. Is there a difference between preventative and therapeutic therapies, or do those refer to the same thing?
For specifically Organocell, and the therapeutic that we are going under is specifically to treat diseases. So we are not running any kind of study on age reversal or age preventative as a preventative. We do understand that there's a lot of anti-aging benefits that come with it, but our focus 100% is on really understanding what are the changes that happen on populations that already have a diagnosis. So meaning COPD, which is a chronic obstructive pulmonary disease where these patients are dependent on oxygen, and their quality of life is dependent on that lower amount of pulmonary function, our impact will be measuring exactly if they will depend less on oxygen or if they're going to be able to compensate with the amount of pulmonary tissue that they have a bigger amount of oxygen. So that is where we're measuring. For example, osteoarthritis of the knee, those are patients that come with pain, stiffness, and limited mobility. That's exactly what we're looking for. So we are in Organocell looking for a specific disease that can be measured, a change in their quality of life.
Yeah, I think that's a great place to end off today's session at. So again, thank you so much, Dr. Mitrani, for joining us today. I do have some last reminders, especially about the quiz for our students, just before we wrap up. So for those who would like to receive credit for your attendance today, you must pass the quiz to receive a certificate. That quiz is now posted both in the same chat box that you posted your questions in and also on our website. So 2 places that you can go to. If you go onto our website, just under the virtual shouting page, if you scroll down a bit, we have a Monday quiz and a Thursday quiz. It'll be on the right-hand side, the Thursday quiz, and that's going to be due next Wednesday, November 16th at 11:59 p.m. Central Standard Time. So just be sure to get it done before then. And like I said, after passing that quiz, you will receive a certificate to the inbox or the email address that you list on the quiz. Just be sure it's one that you're comfortable with. We highly recommend using a personal Gmail, Yahoo account, just a personal account in general, oftentimes because those will not filter out emails. Just in case you don't receive it though in your inbox, please check your spam. And even if you don't receive it there, feel free to shoot us an email and we can help resolve it. Our email contact is down below in the description. So if you ever need to get in touch for any questions, or if you're having trouble retrieving your certificate, we're definitely here to help. And for our next shouting session next week on Monday, November 14th, we're going to have Dr. Sammy join us. He is an otolaryngologist at the University of Cincinnati, Gardner Neuroscience Institute, and he's actually a subspecialist in the field. So that's going to be definitely an interesting session. Join us for that one. I think that's going to be our first otolaryngology session actually so far. It's going to be the same time, 7 p.m. Central, like I said, Monday, November 14th. And just a reminder, if you ever want to join us for other shouting sessions, you can do this through the same way that you joined this shouting session. We just live stream them. Like I said, Instagram and our listserv are 2 great ways to stay in tune. Dr. Mitrani, I know that you have an Instagram. Would you mind sharing your handle for any students who would like to get in touch?
Yeah, it's Mari Mitrani.
Okay, pretty simple then.
I'm not creative there. Okay, but thank you so much, everybody, for joining today, and thank you so much for the invitation.
Absolutely. I hope everyone has a great rest of your night, and we'll see you next week.